Hi, welcome everybody. My name is Dr. Khalid Abu Haliq. I'm the Vice President of the Emirates Society of Ophthalmology Oculoplastic Surgeon. On behalf of the Emirates Society of Ophthalmology and on behalf of all of us here, I welcome you to this educational series, which is going to be about thyroid eye disease. This is the first session of the educational series. We'll have another session in about a week. And we are so lucky to have with us Professor Francesco Quaranta Leoni, who's a consultant oculoplastic surgeon and medical director of the Oplastica Rome. Sorry about my pronunciation, in Italy. He's an adjunct professor of ophthalmology at the University of Pavia, Italy, and adjunct professor of lacrimal and orbital surgery at the University of Ferrara, Italy. He is a past president of the ESOPers, an international associate member of ESOPers and the AAO, and executive board of the AIMO. He's in the editorial board of Orbit and the reviewer of Orbit Ophthalmic Plastic and Reconstructive Surgery Journal, as well as the Clinical Ophthalmology, American Journal of Ophthalmology Case Reports, and of course, British Journal of Ophthalmology. Welcome, Professor. Also with us, Dr. Hashemi Nizar. Dr. Hashemi is a consultant ophthalmologist, consultant pediatric and oculoplastic surgeon, and the head of department at Dubai Hospital in Dubai Health. He's an adjunct professor at Sharjah University and Dubai Medical College in the United Arab Emirates. He's also has been running the residency program at Dubai Health at Mohammed bin Rashid University and the board editor of Dubai Medical Journal. We will start with Professor Francesco talk, which is going to be really eye-opening for all of us, I'm sure. You can go ahead, Prof.
Can you see my first slide?
Yes, we can.
Great. So thank you very much, Khalid, for this wonderful presentation. It's a great honor to be here, invited to talk by the Emirates Society of Ophthalmology and you. And I mean, feel free to interrupt if you want to ask questions. So my talk today will be about diagnosis and assessment of thyroid eye disease, which is quite a complex topic. And we all know there is a lot new very, very recently, and every day there is something new about it. So let's not waste time, and I'll go ahead. These are my financial disclosures, and we know that thyroid eye disease is the most common extrathyroidal manifestation of Graves' disease. And also, we all know that we will see thyroid eye disease when there is Graves' hyperthyroidism. It is a little bit less known that thyroid eye disease may occur in patients that are actually euthyroid and hypothyroid. The best example being ladies with Hashimoto's thyroiditis who had a period of unknown hyperthyroidism, a long period of time of euthyroidism, and then end up with hypothyroidism and may develop thyroid eye disease. Anyway, if you have a patient with Graves' disease, then 25 to 50% of this patient will develop thyroid eye disease at one stage, also within 1 year. And whenever you have patients with thyroid eye disease and unknown problems in the thyroid, so you just see patients not like these three, but with a milder aspect of the disease, but then they will develop hyperthyroidism within 18 months. What do we have to know about prevalence and incidence of this disease? Well, prevalence is 50% among Graves' disease. So if you have Graves' disease, you will get thyroid eye disease in most of the cases, but 50% will have it while you see them. And the incidence varies a lot between male and female, as we'll see a little bit later. I mentioned that hyperthyroidism is very common, but still 5% of these patients will be hypothyroid and 5% will be in a euthyroid state. And the age usually is between the third and the fifth decade of age. And if you are older, you get the disease in a more severe form. And there is a difference between the incidence in males and females, as I mentioned, because there is is a little bit earlier in female, usually 40 to 44 or 60 to 64, and 5 years later in male. And the female preponderance is 5-4 to or 5-1. So we usually is a middle-aged lady that will be affected by thyroid eye disease. And as men tend to have a late onset disease, this will be more severe because the disease tends to be more severe if it starts later. And what about ethnicity? So it is worse in African Americans, and then in Caucasians, and finally in Asians who have, for Asians, I mean, Far East and the Pacific region, they would tend to have a different type of disease we see later. What can we do to help these patients? Of course, there are some risk factors that are not modifiable. The ethnicity, the gender, if you're a female, with respect to a male, the age, if you are older, you will get a bad disease. If you had previous radioactive iodine therapy, and especially what it is very important that hypothyroidism following radioactive iodine therapy is quite dangerous. So it's very important after radioactive iodine therapy to test immediately your thyroid state because it can exacerbate thyroid eye disease. If you have a positive family history, this you cannot change. If you have a thyroid dysfunction and the presence of antibodies, TSH receptor antibodies, and systemic association with other immunological diseases, with rheumatoid arthritis, lupus, Addison's disease, vitiligo, or celiac disease. This unfortunately not modifiable, but there is something we can do for these patients. Smoking, I will insist a lot about smoking, 7.7 times more likely to develop thyroid eye disease than non-smokers. And this is the smoking, it is proved that stimulates hyaluronic acid production and increase in adipogenesis. And also it has been studied that most of these patients have a selenium deficiency. So it is important to supply these patients with selenium, and is enough to give them 100 micrograms twice daily for 3 to 6 months. Also, now it has been very recently stated the association with high serum cholesterol, so statins are very useful in thyroid eye disease and pregnancy. And we always say that stress determines every disease, but for thyroid eye disease, to try to cut the life stressors is very, very important. So what about the pathophysiology? There are still some things that are unknown, but there are some there is an immune reaction that is against some antigens that are shared by both the thyroid and the orbit. So in the orbital fibroblast, there is in these patients an overexpression of two receptors, the IGF-1 receptors, that is the insulin-like growth factor 1, IGF-1 receptor, and the TSHR, the thyrotropin receptor. These two receptors are very close. The antigens just stimulates these receptors with a cascade of production of something like interleukin that would stimulate both the differentiation of adipocytes, so the adipogenesis starts, and also differentiation into myofibroblast, which determines the muscle fibrosis. So antigens, stimulations of two receptors that are together very close on the orbital fibroblast, and there is a cascade of immunological cascade of interleukin and other inflammations, mediators that will stimulate the adipogenesis and the fibrosis of the fibroblasts. And so what the derivative of this is inflammation, secondary edema, and then what we all know, the expansion of the extraocular muscles and the adipose tissue. And we all know that the orbit is special, so there are many vicious circles. Everything is being studied now, but stop smoking is very important. We repeat it 3 or 4 times. So we have to tell this patient to stop smoking, investigate if they are smoking or not. And the key is inflammation and new adipogenesis, which is what determines the very big inflamed orbit and swollen muscles. How can we review the symptoms? It's easy if the patient have typical hyperthyroidism. So they will complain of restlessness, of intolerance to heat, weight loss. They will be sweating, palpitations, especially. They will tell you that when they go to bed, they will feel a very strong heartbeat as soon as they rest. And for women, especially for women, thinning hair and menstrual irregularities. But some patients, 5 to 10%, will be euthyroid or hypothyroid. So in some of these patients, we can have weakness, fatigue, intolerance, not to heat but to cold, weight gain, constipations, and dry skin. How we make the diagnosis? Of course, if we have both the ocular findings that are very typical and thyroid disease, that will be very easy. That it's more difficult if ocular features are there and we don't have any known signs of hyperthyroidism or at least of thyroid dysfunction. So we have to gather an appropriate history. Which laboratory tests do we order? Of course, the FT4 is more important than the FT3, so the free T4. Then the hormones TSH and the antibodies that I'll go again to the antibodies TSI and TBI. I will tell you exactly what they are. Some ancillary tests that we see, again, ask the smoking status, test the selenium, and test vitamin D, because in most of these patients there is a low blood level of vitamin D. We have to know something about the history, the systemic thyroid eye disease. There is an autoimmune thyroid condition. What were the symptoms? How was it managed? So we have to know something about the history of the patient, especially if they are under medications or if they have the radio iodine therapy. I told you why. Do they use beta blockers? And again, remember that tobacco increases the risk of thyroid eye disease by 7.7 times. If our suspicion is high, we have to ask the antibodies. Of course, we usually ask the TRAB, which are the TSHR autoantibodies, but TSI and TBI, the first are thyroid-stimulating immunoglobulin, the seconds are thyroid-binding inhibitor immunoglobulin, are correlate to disease activity. And how do they correlate? The TSI has shown a more significant association with clinical features of thyroid eye disease than TBI. So we should ask the TSI, which is a perfect functional biomarker for thyroid eye disease. Is very useful in the early detection of thyroid eye disease. It correlates with the activity and severity of thyroid eye disease. I will tell you shortly what it means. And it correlates with recent onset of dysthyroid optic neuropathy. So we have TSI are very important. Why smoking is important? Because there are several studies. It's just not to say. And also, in the smokers, there is a disease progression and a longer lag of activity. And if there is a dose-response effect, so the more you smoke, the worse the disease is going to be. And also, if they stop smoking, they will really improve their status. So this is, again, very important. Even for me, I'm a pure oculoplastic and orbital surgeon, but I don't have to forget that I've been an ophthalmologist in my past life. So whenever you test this patient, I always tell my residents and my fellows that you have to spend at least 45 minutes with one of these patients, because otherwise you don't know exactly what they have. When you have an orbital patient and a distal patient, spending time is very important. So it's important to test very carefully visual acuity and to assess that they don't have a decreased vision for any other reasons, problem in the retina or even a cataract. So ductions, test motility, see the adnexa, see if there is a lid edema or something else, test the test the exophthalmos with the Hertel if possible, and test the vision with the color plates, because sometimes we have a little bit of decrease in color vision, and this starts much earlier than decrease in visual acuity. Test a very subtle pupillary defect, afferent pupillary defect, to see if there is the optic nerve is affected. Test the IOP, because there are problems with the intraocular pressure for several reasons. There is open-angle glaucoma, which is associated for several reasons. There is no time to discuss this, but there are lots of reasons to have increased intraocular pressure in these patients, and especially if they have a tight inferior rectus muscle, it's very important to test the intraocular pressure both when they're looking straight, so in the normal position, even when they look up, because if they look up, the fibrotic inferior rectus muscle will press or will pull on the eyeball, and intraocular pressure will increase. Of course, anterior segment, posterior segment to see the optic nerve, and visual fields and OCT we'll see when they are useful. Let's have a look at this patient. The typical sign which is present in 90% of the patient is upper eyelid retraction. And we have to test it measuring the MRD1, which is the line that starts from the lower edge of the upper eyelid to the eye reflex that we project into the eye. And again, for lower eyelid retraction, the MRD2. The two together form the palpebral aperture, but palpebral aperture may be the same in both eyes if you have, for example, upper lid retraction orthosis and a malposition of the lower lid. So we always have to rely on MRD1 and MRD2. And we do it with a ruler now, which is rather imprecise, and what we aim for really the immediate future, I mean next year, is to use artificial intelligence to test this, because the data we obtain with AI are objective, precise, and accurate, and the acquisition is easy, very reliable, automated, as you can see here. And we use line segments to calculate output measures, and we can use normative data and compare sides. And the future is not just palpebral aperture, but facial metrics. We'll see later how important is disease phenotyping, monitoring, and prediction. And currently, artificial intelligence has proved to be very, very effective in just diagnosing thyroid eye disease. TAO is the same, thyroid-associated orbitopathy. It means thyroid eye disease. And also, it has been shown that if we use artificial intelligence, we can detect very early optic neuropathy, and AI outperforms the experts in the field. So this will be very, very important in the near future. So we will abandon the ruler and we'll use AI. So let's go to the clinical manifestations. I mentioned that the eyelid retraction is present in more than 90% of the patient, is the most sensitive signs of thyroid eye disease. More commonly, we see upper eyelid retraction, but in other patients, we can see lower eyelid retraction. Sometimes lower eyelid retraction is determined by exophthalmos. Exophthalmos causes lower eyelid retraction, not necessarily upper eyelid retraction. And of course, we have to make a differential diagnosis. Let's see some cases. This was a lady that was referred to me for right upper eyelid retraction, but she had a left ptosis. So this was just for Herring phenomenon. So try to compensate for ptosis. She was overacting with her right levator muscle. So the cure in this lady is not to cure the right secondary retraction, but to raise the left upper lid. So she had a Mueller muscle conjunctival resections, and automatically we corrected the Herring phenomenon, just operating one eyelid. Then this is a lady who presents like this, and we know from her that was just a ptosis overcorrection, and so the cure here is the same that you would use in a dysthyroid patient to lower her left upper lid. This is an interesting case that seems to be really a dysthyroid lady. I put this slide just now because I saw this lady yesterday in my office. And this is very interesting because you see this lady with upper eyelid retraction and she has an hypotropia of the right eye. But this is a lady who presented, this was a picture she gave to me, and she had just ptosis overcorrection. So let's try to have a correct look at the patient and see accompanying signs to, and always ask the correct questions to the patients. What is very important when you see lid retraction is the lid leg. I won't annoy you with all the different Stellwag, the Leinpel signs. You can find them in any book. What it is very important is the lid leg. The lid leg is this movement. Whenever you have upper eyelid retraction and you see that there is a contraction of the Mueller's muscle and the levator muscle, and when the patient look down, there is the upper eyelid doesn't follow the eyeball. So this is pathognomonic of thyroid eye disease. And what happens when we have an inferior rectus fibrosis? We can have secondary upper eyelid retraction, like in this case. You see that this gentleman has, of course, a squint in his left eye with esotropia and hypotropia, but a very bad upper eyelid retraction. Upper eyelid retraction increases when the patient looks up, but there is no lid leg. So in this patient, there is, of course, thyroid eye disease. The Mueller's muscle and the levator muscles are not interested, and the upper eyelid retraction is just secondary overaction of superior rectus muscle that try to overreact while the eye is pulled down by fibrotic inferior recti muscles. And we know the superior rectus muscle is strictly connected with the levator muscle. So while the patients look up, there would be an over contraction and an overreaction of the levator muscle. This is very important to distinguish this case from the previous ones. And also, what about lower eyelid retraction? Is it always due to thyroid eye disease? Of course, there are other causes of lower eyelid retraction. This lady had a previous orbital fold fracture, so always investigate. This lady had an inferior rectus recession, so we know that when we recess the inferior rectus, we might end up with this. And this lady had a transconjunctival blepharoplasty. So we always say that there is no lid retraction, but even you can have an atrophy or scarring of the septum if you do transconjunctival lower lid blepharoplasty. So we have to investigate. What about extraocular motility? We know that there is a restriction in 40 to 50% of the patient. There are other patients, we have to make a differential diagnosis. Sometimes when we have a pattern of squint that we cannot identify, we can think about palsy, the trauma, an orbital disease, or myasthenia gravis. But this is quite typical of thyroid eye disease. And what do the patient complain of? We'll go through imaging shortly, but these patients start complaining of problems while reading. Sometimes they say that they have double vision while they rest in bed. Always ask if these patients have a TV screen in their bedroom, and they complain to seeing double vision when they rest in bed because they have in this vertical refixation. Then they begin sometimes, if things get worse, to have a sensation of pain or stretching on eye movements. And in the end, they have constant restriction with constant diplopia, predominantly vertical. You can see here that all the extraocular muscle may be affected. Usually there is saved the lateral rectus, but the inferior recti and the medial recti are very often involved. You can see another case. This is very typical, exophthalmos with inferior rectus involvement, and you see how increases upper eyelid retraction in attempt upgaze due to overaction of the superior rectus of the levator muscle. In other cases, you can have an anomalous head position to try to compensate double vision. And if you see a lady like this, you just reposition her head and you see that there is a very bad inferior rectus restriction that may be present without exophthalmos. And sometimes you can have, as you can see here, lower eyelid retraction with medial recti involvement. So there is no involvement of the inferior rectus, but both medial recti are involved with a right esotropia. So first inferior rectus, then medial rectus. Then the third sign, proptosis. What can we do about proptosis? Most of the patients will have proptosis, and we have to investigate the cause of proptosis. So this case is typical if it's bilateral, but sometimes this is another lady which I saw recently who complained of left exophthalmos. This is, to me, easier if you don't have artificial intelligence than the exophthalmometer to put the patients in rest and looking up, and you can easily see that the left eye is more prominent. But is it the left eye more prominent, or there is a relative enophthalmos in the right eye? First, ask the patient. The patient had previous sinusitis, so with imaging, with both CT scan and MRI, you see that there is an imploding antrum in the right eye due to previous sinusitis, and this is the silent sinus syndrome. So there is not exophthalmos on this side, but enophthalmos on the other side. So the management will be completely different. In other cases, this is quite rare to have a bilateral carotid cavernous fistula. And again, if you see a patient like this, you may think to exophthalmos and acute thyroid eye disease with an active, very active thyroid eye disease. Again, imaging at the CT scan, you will see bilateral superior orbital vein enlargement, and the angio MRI will help to identify the majority of vascular problems that are related with carotid cavernous fistula. And then other clinical manifestations, of course, pain. Patients, if they have upper eyelid retractions, may have SLK, superior limbic keratoconjunctivitis, tearing and photophobia, many patients. And then blurred vision. It is very important to investigate an early optic neuropathy. So how do we investigate early optic neuropathy? Not necessarily with, as I mentioned before, with decreased vision, but let's check the color vision, a very subtle pupillary afferent defect, a visual fields defect in 70% of the patients. Some will have optic disc edema. And then finally, if there is apical crowding, there will be a decrease in visual acuity and altered signs in the retinal nerve fiber layers and visual evoked potentials. What we'll go through this very rapidly to detect the very early signs in the visual fields that are very important. Imaging is very important. We know ultrasound of course, low cost, but it's not very useful. Basically, we have to do when we have exophthalmos and we have to make a differential diagnosis, either a CT or an MRI or both. Why? Because CT is very important to identify the bone, so I would not decompress a patient without a CT. There is a typical enlargement of the muscle with sparing of the muscle tendons, with this typical, very typical, the Coca-Cola sign of the bottle sign of the muscles. And we have to assess the apex. I told you, and I will repeat, that the inferior recti and medial recti muscles are very often affected. And MRI, why is it useful? Outperforms CT in the assessment of the disease activity. So MRI is very useful to assess active patients because with the STEER sequence measures water and suppressing fat signal can highlight the areas of inflammation. So if you have any doubts, then we will need an MRI. Also, assessment of proptosis, you see that is very much more reliable than the exophthalmometer, than the Hertel, and even artificial intelligence will detect exactly the exophthalmos with the MRI. And you see in the CT scans that there are some patients with increases in intraorbital fat, which is all the black you see here, and with very thin muscles. In these patients, there might be a very big exophthalmos with stretching of the nerve. And imaging, when you have a patient like this, you see there is a pupillary defect. This is an acute phase with an optic neuropathy. And whenever we do a CT scan, we see that there is a very big medial rectus muscle which is pressing on the optic nerve. So this is why there is optic neuropathy. And you can see here, again, very big muscles with saving and pressing on the optic nerve bilaterally with saving of the insertion. And you can see it here. But if there are other cases, as I mentioned, with thin muscles. And even in these cases, there can be optic neuropathy due to stretching of the optic nerve. But let's go to the apex. There are some active patients without exophthalmos. This is a Caucasian lady, but you can have this in Oriental patients. Sometimes you have either white eye or active patients with no exophthalmos and very tight muscles with presses on the optic nerve. So always assess the apex. And you can see here what does mean apex crowding. You can not even distinguish the optic nerve, which is here with all the 4 recti muscles, which are increases in size. And of course, what differential diagnosis of both CT and MRI are very useful, because whenever you have an orbital inflammatory disease, which is not thyroid eye disease, then in this case, you see the difference between thyroid eye disease. Again, I will repeat it because it's very important, sparing of the tendon and involving the tendon in other inflammatory disease. For what concerns the early optic, early signs in the visual fields, you have to worry when you see in an inferior visual field defect, because you will have a patient like this with a very big superior rectus that presses against the optic nerve. And whenever we see these patients, we have to start immediately either with medical therapy or with surgery, because I usually advise early decompression in these patients because they have a lower threshold for early intervention. So this is a very early sign that is very important to detect. And whenever we have any doubt, of course, we can go any step further with the OCT, but we all know about that. Very quickly, let's talk about how to distinguish this patient. The activity versus severity of the disease. Treatment varies, so we have to distinguish between an active patient and a severe patient. This is the Rundle Scarvel. Randall Scarver. Randall was the first who tried to distinguish between the dynamic active disease, which can last usually from 12, 18 to 24 months up to 2 years. Then all patients have a plateau and they enter in an inactive, stable phase when there is fibrosis. This can last up to 5 to 7 years. Usually the active phase is 1.5 years, then there is a plateau, and then we start on the inactive phase. It's 25 years that all people that study thyroid eye disease have tried to classify the patients and understand if they're active or not, because treatment is very important in the active phase. So we have to start treatment. You will see with Mario Salvi next week when they are in the active phase. And so Martin Mauritz has published in many years ago the clinical activity score. So when we see the patients for the first time, we have 7 points. You see pain, redness, and swelling, and we give the patients a score from 1 to 7, and we say that the patient has a score of at least 3 is in an active phase. Then at follow-up examination, we study the impaired function. So the score increases from 7 to 10. And we say that the patient is active if there is a score of at least 4 out of 10. There are, even if this score is still used, and it's quite accurate in predicting the outcome of the therapy when we use immunosuppression therapy. Still, you see that the problem of CAS is that we give 1 point for decrease of visual acuity and 1 point for a swollen caruncle. Of course, there is much less important to have a swollen caruncle, even if it's a mild sign of activity of the disease, than a decrease of 1 line of the visual field, or a decrease in a worsening of the motility of the eyes that will highly impact the quality of life of the patient. So this is the main criticism of the clinical activity scores. This is for the activity. Then we have to classify the patients for the severity of the disease. So many years ago, there was these no specs classifications with 6 degrees. You see, this is the acronym of no signs or limited signs, soft tissues involvement, proptosis, extraocular muscle involvement, corneal involvement, and sight loss. Of course, if we have a grade 6, we'll have all these signs, and it would be a very bad disease. But the problem of the no specs classifications is there is no distinction between inflammatory progressive disease and a stable non-inflammatory disease. So what we use now is either the VISA classification that is mainly used in the United States and in Canada, and basically is the acronym of vision, inflammatory signs, and the visual acuity, and all the other signs. It is very important to give a score of 0 to 8 to the eye, to the inflammatory score, and of course has the vision, the appearance of the patients, and the squint, so the strabismus of the eye motility. So there are 2 scores, 1 for the VISA altogether and 1 for the inflammatory scores. In Europe is mainly used the UGOGO classification, which classifies in the thyroid eye disease into mild or moderate to severe, or in severe and sight-threatening. So I won't talk about severe or sight-threatening because we all know what it is, but mainly when we see a patient, we have to tell the patients, okay, dear lady, you have a mild thyroid eye disease or a moderate to severe thyroid eye disease. and we consider the effect of double vision, the eyelid retraction, the exophthalmos, or the soft tissue involvement. So the UGOGO classification is quite clear. To make things more complicated, now especially in the UK, Jimmy Udin, who is a very good friend of mine, has classified thyroid eye disease into different phenotypes. And even if you have no CAS, so no very low CAS, then you can have a white eye apex type. You can find it in the books, but just to let you know that sometimes these patients will respond well to decompression, but they can have white eye and they have a very, very tight orbits with not very big exophthalmos. Or in other cases, especially in children, there might be the white eye expansion type with increasing fat, very thin muscles. And usually these patients don't respond very well to immunosuppression. So the phenotype might be more important than either, say, a high or a low CAS, or a high or low VISA score, or have apparently a moderate to severe or a mild thyroid eye disease. So how do we manage thyroid eye disease? The team is important. It's not strictly necessary, in my opinion, as UGOGO people say, to have the endocrinologist and the ophthalmologist in the same room, but they have to talk to each other. Smoking cessation clinic is very important. Audiology exam if you want to start teprotumumab, and a connection if you're not doing squint yourself, to have a good relationship with a squint surgeon. Very, very quick talk and about what we do surgically. Usually these patients have 4 problems: exophthalmos, double vision, eyelid retraction, and cosmetic problems. So what we were thought to do is that a 4-stage operation to be considered the most effective treatment in the management of stable thyroid eye disease, as every operation may influence the following surgical steps. So usually we start with the orbital decompression, we follow with strabismus surgery, then we do eyelid retraction correction, and we end up with cosmetic surgery. But recently, there has been a shift towards endoscopic medial wall decompression. It's very important to preserve the strut, which is this bony part between the medial floor and the medial wall of the orbit, to avoid the displacement in the orbit. With the medial wall decompression, we can preserve a band of periosteum to avoid the displacement of the orbital content into the paranasal sinuses. So we allow air into the orbit without displace the orbit. With strabismus surgery, the success is to improve the muscle function, and we have to improve binocular single vision in primary gaze. And what I do now is just this intraoperative relaxed muscle positioning technique. So I don't do any more very big inferior rectus recession, so medial rectus recession. You just cut the muscle, you see where the eyeball reposition itself, and you put again a suture, and you will end up recessing the muscle usually not more than 5 or 6 millimeters, not more than that. And also upper eyelid retraction is very standardized. We usually do a Müllerectomy, so we cut the Müller muscle to correct up to 2 millimeters of upper eyelid retraction, and we do a graded blepharotomy, which is recess the levator, do an anterior Müllerectomy, and cut the conjunctiva, preserving a bridge for bigger recession. And with this case, we obtain a good upper lid retractors recession. And for lower eyelid retraction correction, what is very important to remember is that we usually need a spacer that can be usually or in either hard palate or dermis. In other countries, they can use porcine dermal collagen implant, but this is can be prohibited for some religious in some countries, and also in Europe, for example, we don't have Alloderm, which doesn't have the CE mark. And what I tend to do now is combined surgery. So these patients cannot, in Italy or in Europe, we don't have access to teprotumumab now, so we still use a lot of surgery and combined surgery same time. So this is what you can do with combined surgery, doing bilateral decompression, bilateral dermagraft, or in this lady doing bilateral graded decompression and recessing one muscle. So this lady just 6 days after the operation. And even in this case, you can do a blepharoplasty, blepharotomy, and decompression. And another sign which is very important, sometimes you don't have eyelid retraction, but it's ptosis. Ptosis is very dangerous because it is an expression of very tight orbit. So do visual fields immediately in this patient who have a lower threshold for early decompression. And again, this is the gentleman that you knew before. I usually don't do a medial rectus recession because it can be, we can talk about it another time, can be affected by decompression, but you can treat it with 2 stages and obtain reasonable results. So in some cases, combined treatment is quite useful. How teprotumumab will change surgery? These are not my cases. I borrowed these cases from Don Kikawa. Medical therapy and surgical therapy can go together in some cases. You can improve the patient, you can treat him afterwards. And even with squint, there is a significant improvement following teprotumumab, and you will have normal muscle. So there will still be room to treat this patient surgically afterwards. To conclude, because I've talked a lot, this is the conclusion of what happened in Napa Valley last spring. It's been just published, so in this the last number of ophthalmic plastic and reconstructive surgery. We know a lot about pathophysiology, but there is still the role of the IGF-1 is controversial. We know that there are some risk factors. I've talked about that, and again, smoking is dangerous, but we are now addressing low vitamin D, sleep apnea, and high cholesterol, which is very important. We are all influenced by CAS, but remember the other classifications and remember the phenotype. So we have to recognize which type of patients we have in front of us. And also remember that the FDA does not consider CAS as an approval metric, even if it's still used. And there are a lot of new therapeutic targets, agents, of course, the anti-IGF-1 receptor and TSH receptor, and more recently, the neonatal FC receptor, and other are studied the interleukin pathways. We have to monitor these patients for adverse effects, even if we new agents relapse tends to happen in only 24% of patients that can be retreated with effectively, and also in the side effects are very low. And the long-term efficacy is what we have to study in the future, and of course do more trials with effect durability of at least 24 weeks. So I concluded. I hope I have been clear enough and that I haven't talked too much. So I stop my screen and we can see the clinical cases.
Thank you very much, Professor, for your very enlightening talk. I'd like just to mention to the participants, you can put your questions in the Q&A in the Zoom section. And now we'll do the clinical cases with Professor Hashemi Nizar. You can go ahead and share your screen.
Thank you, Dr. Khaled. Thank you, Professor Francesco, for the exhaustive and very informative lecture. I am trying to share my screen with the the system here. Okay, give me just 1 minute to find the way to share it. Here it is. Share my screen. PowerPoint. So you can see my screen at the moment. Yep.
Yes, we can see it.
Okay, so let's start. I will try to shorten little bit the talk and to skip some slides that might overlap with Professor Francesco lecture. And now we are all experts, so I will take you throughout, let's say, a daily clinic journey of an oculoplastic surgeon, and to show a couple of cases, and you will have to answer to probably questions. So the first case is Aisha. She's a 30-year-old female presented with a mild eye dryness. She came for blepharoplasty to my clinic. She noticed a change in her eyelid since 1 month. She has no double vision, no particular history, and the initial thyroid testing were all normal. So here is Aisha. As Professor Francesco mentioned, is it right eye ptosis or left eye retraction? So we have almost a pathognomonic sign for this patient. When the patient looks down, she has retarded descent of the upper lid. It's a lid lag or von Graft sign. So we know that the lady has left side lid retraction. After 2 months, the lady came back. She is now like this. As you see, she worsened with more retraction on the left side, and she has mild conjunctival injection, and she has a mild proptosis. So now let's say that the diagnostic seems to be more clear, to be an thyroid-related orbitopathy. So in this situation, what will be the best useful monitoring process to do for you? You have 4 options. Please, you can answer and vote, and I will tell you what is the average answer. Please, if you have it, you can answer from your side for the audience.
Yeah, just click on the
Yeah,
from your
you
side.
can click, you can see the questions, doctors. Yeah. You can see Dr. Khaled yourself also.
Yes, I can see them.
Okay.
I can see question 1.
So I don't see the whole pool of questions. Okay, so yeah, here 77% of the attendees have answered answer B, which is the right one. The clinical activity score is the best. Why? Because it's a valid tool to assess the thyroid orbitopathy, and it monitors also the changes and the progression over the time. So these pictures I used to show to my doctors or my patient to tell them that do not look at the shape of the patient or the external aspect to judge of the severity or the progression of the patient. Here we have 3 examples. I used to show these 2 ladies on the top and the lower part, and this lady as well. And I tell to the patient, which of these 3 cases is the worst one or the most severe one? So most of the ladies will answer which this is this one, because they have like severe soft tissue changes. Most of the patient will answer that it is this lady with the huge proptosis, exophthalmos. Very few of them will tell me that this is the most severe case. But if we look at all the classification or the way that we classify the patient, we will find that this lady who has an Asian type of the orbits, which is narrow, is the most severe case because she has already visual involvement, decrease of vision. All the others, this lady is a Caucasian type. She has a large exophthalmos that protects the optic nerve. And the other lady, the third one, is a soft tissue only involvement, and there is no sight threatening, nothing. So classifications are very helpful for that. So as Professor Francesco said, the most common sign that we see is the eyelid retraction. And the ladies are coming for cosmetic purpose. They don't know. And most of our colleagues, they don't think that it's the retraction. They look at the ptoosed eyelid unless it is very severe. So this is very common and helpful. The next step for the patient to help us in the diagnostic for Aisha, we went for an imaging. Here you can see on the top on CT scan. At the lower part, you have an MRI. You can choose either one of the or the other, depending on the facility that you have. So and then you can see that we have a mild thickening of the muscle. Here we can see the medial rectus, which is thickened compared to the other side. So at this level, which imaging finding would most strongly support a diagnostic of TED for you? We had the imaging before. So what is out of this proposition the best one to tell you that it is a Graves orbitopathy or thyroid-related orbitopathy? So I'm waiting for your answers or vote.
Yeah, please start answering with the.
Yes, please. You can start if you have it on your hands. So it takes a bit time to have the pull of the questions. Okay. Yeah. So 90% of you have answered the right answer because it was mentioned before. The tendon sparing muscle is thickening. So the tendon is usually normal in this case compared to the other situations. It was shown before. Here you have a case of myositis where you can see that there is a thickening of the tendon, and in the other situation, the tendon is well respected. So 6 months later, her thyroid function test was still normal. The receptor antibodies were still normal, but the symptoms has gradually worsened. Which of the following statement about the thyroid eye disease and thyroid function is correct? So you can answer. All right. So let's say 80% of you have answered the right question, the rest are right answer. So TED can develop even if the thyroid test, and there are many publications showing that even when the markers, the usual markers are negative, the patient can still have a thyroid eye disease. So we need to rely on clinical evaluation. I think it's the last question for this case. Which of the management strategy is the most appropriate for the patient for mild to moderate thyroid orbitopathy? What would you start for your patient in the clinic? There is no sight threatening. She has mild eyelid retraction. We are talking about here of okay. I think it will be more controversial, the answer for this one. Yeah. So yeah, I was expecting this kind of answer. So most of you have answered steroids, more than half, but still 40% of people have answered selenium supplementation, which is the right answer. So for this patient, which is mild, she has no other signs except the eyelid that has to be treated separately is the selenium supplementation. What's the selenium? The selenium is an antioxidant. It was mentioned before, and we know that in patients with thyroid disease, the markers of oxidative stress is higher. So the usual intake in the food is 70 microgram recommended in Europe, and I think for all humans. And for Graves orbitopathy, there are many studies. We need to supplement the patient by 100 to 200 microgram daily. So let's go to the second case. It's going to be short. So it's a 72-year-old male with a history of treated hyperthyroidism 10 years back. And he recently noticed a bulging eye, and he reported decreased vision. Here is the gentleman. You can see that the left eye is a bit deviated on the top. He's in hypertropia. So the first question, which is the following aspect of this patient that it is atypical of TED? So deviation can be part of the TED. He's an old male. It's not the usual case. but there is something else that you have to look for. So now the answer is half-half. So unilateral eye bulging, and for some of you, it's absence of eye pain and redness. So the answer is B, because it's his thyroid eye disease started 10 years later. As Prof mentioned before, it's within 18 months. So the unusual things here are, it's a tricky question because the patient is an old man, this is not the profile, but the question here is a 10 years history of hyperthyroidism, and then only he developed an orbitopathy. So this is the right answer. I think it's the last question for this one. What is the next exam to do for this patient? That's easy answer for this gentleman. You have to exclude all the differential diagnostic. He has a proptosis, mild redness, and deviation of the eye. I'm waiting for the answers. All right. So yeah, almost the majority answer that we need to have an MRI as soon as possible to exclude any processes or any orbital mass pushing the eye. So here you can see the MRI. We can see the enlargement of the muscle. We had several examples before. I can give you just a mnemonic word. I'm slow. So usually the inferior rectus followed by the medial superior levator lateral rectus are the muscle that we've found usually involved in it. Keep in your mind that the MRI is not only an anatomical exam, but it can give you, especially with DTIs, diffusion tensor imaging, some functional information, let's say bio or let's say inflammatory markers. So you can evaluate the muscle and see whether it is full of water. You can evaluate the water, and if whether the muscle is more of fibrous. This also can give you some information related to the activity. So most of the time, the eye muscles are either restrictive. We have restricted squints. Then muscle can be fibrosed. They lost their elasticity, and deviation can be vertical, horizontal, and the diplopia can be also torsional. We've done some work on the torsional deviation, which is quite common in the Graves' orbitopathies. So the optic nerve in TED. So easy test in your clinic, even if you are not an eye doctor, is the color test of the patient. You can check the red vision, for example, of a color. The second test to be done is a visual field. You can do a confrontation visual field or ask for a visual field. And of course, imaging is the most important to help and to see whether we have a compression or no of the optic nerve. So don't wait for the picture that was shown before by Professor Francesco to see complete crowdiness. Here, this nerve is compressed because all the blackish things around is also fat that transmit the compression to the optic nerve. So this patient, you found that he has a decrease of vision, color vision is affected, and mild lag of ophthalmos. So your MRI show an enlargement of the muscle. So based on this finding, what is the stage of this patient? Now you have the classification. Is it mild, moderate, severe, sight-threatening? Okay, we have all the voters. So yes, it's a majority of sight-threatening because we have a decrease of vision. Yeah. So the patient was admitted and given high dose of methylprednisolone for 3 days consecutively. He showed an improvement, but let's say after 3 days, he again deteriorated his vision. What is the next step? So what's the sight-threatening? You have either corneal exposure like this patient or posterior compression, crowdiness of the apex. as the last classification from Jimmy Udin. So the patient is not necessarily an ugly vision or ugly angry eye. It can be also a compression of the optic nerve. So that give you a sight-threatening. So which is the following treatment recommended for a sight-threatening patient? Stage. So this patient was already given IV steroids. He improved partially and he again relapsed. So what will be the next option for you? For this patient, you have IV methylprednisolone, lower, higher dose, orbital decompression, immunotherapy. What is for you the decision, the best for this patient to improve and to spare his vision? So we have all the answers. So most of you decides for a orbital decompression, 75%. So the answer is there is no consensus in this case. The maximum cumulative dose of methylprednisolone you can give is 6 to 8 grams, not more. If you start on immunomodulator, it has late action and low action to get the benefit. Tepro is not indicated for this sight-threatening, but mainly for the moderate and severe TED, this new generation of treatment. So it's surgery, and I also choose the surgery for this patient. But which surgery to do? So we have many options to operate the patient. For this patient, I decided to remove the fat. I did a fat removal. We went for lateral orbitotomy for this patient to give more space. We removed the lateral orbital wall. And here you can see the lateral orbital wall enlarged. And we also removed the medial orbital wall through an endoscopic approach, through the caruncula, not through the nose. We do retrocaruncular endoscopic approach. So we do a balanced orbitotomy to avoid, or at least to decrease the double vision. I wanted just to emphasize on one case, on one thing, the risk factors, which is the smoking. Professor Francisco insisted a lot on it, but here in the UAE, you have a patient who can swear that he does not smoke at all, but when you see him in your clinic, you feel that the patient is always worsening because our patient in the habit and the culture, we are using a lot of bukhur. So as this lady, she said, no, I'm not smoking, but she's worsening and she has a severe orbitopathy. So this is a question to ask for your specific patient in the Middle East, whether they are or no passive smoker or using bukhur. So the take-home message from my presentation is the earlier that you diagnose the patient it is. So we have a couple of advice on how to do with the new guidelines, but the earliest is the best, and to refer the patient to the right path, specialized people, endocrine, ophthalmologist, and so on. So we have good, let's say, guidelines, clear to help us to tailor and to customize the treatment for our patient. With these guidelines, you can say that this patient, I will offer this or that option to help you in your decision. And every patient is different. This lady, as Aisha, she came with a lid retraction. We don't need to give her any systemic medication. We follow her. We gave her Botox in the beginning because she's in a hurry to be good. And then later on, we offered her surgery. And her problem is for now solved? Not yet. Because this patient is really, for her, a decrease of her quality of life. It's not a simple eyelid problem. She does not go to work because she does not want to be seen like this. It has an impact on the society. And we need the psychological support for this patient. We don't neglect and say, okay, it's eyelid, because we used to deal with more serious case. Graves' orbitopathy, another kind. This patient is bilateral blindness. He came with this situation. So we need to add all the tools we have in our hands, which is corticosteroids, high dose, and surgery, and some prayer to help him to recover the vision. So this one also, we have to customize the treatment according to his wishes and what he wants. Is mainly social recovery. He wants to go back to work, and he doesn't want to have this, in French we say, tragic sight, like a very, very angry sight. And every patient, as I mentioned in the beginning, you need to think for him and to customize what's the best. We are talking about technical management, different treatment, but for the patient at the end, he does not understand all these things. He just tell you, doctor, this is my picture before. I want to be back as before. So this is only what they ask you. Just I was big for like this, and I want to come back to the same picture. So in French, we say, give back the smile, redonner le sourire. So give back the smile to your patient, and thank you for your attention.
We don't have that many questions at the moment. There is just a question for Professor Leoni about the association that he sees between ptosis in thyroid eye disease and in impending optic neuropathy situation. I think the picture that he showed in his presentation, there is a question about how do you see the association between those two. Professor Leoni, if you have an input into this.
Of course. I mean, 90% of patients have upper eyelid retraction, but whenever you have thyroid eye disease and ptosis, usually ptosis is a very fibrotic levator and can be indirect or direct signs of a tight orbit. And whenever there is a tight levator, there is a tight superior rectus most of the times with an inferior defect and optic nerve compression. So whenever you see a ptosis in these patients and a tight orbit and a deficit of infraduction due a tight superior rectus, then you have to be very careful, and it's a very low threshold to decompress these patients.
Thank you, Professor. I think a question from our colleague, Dr. Atimadi, about the association between the TSI-TPI relationship to the thyroid eye disease, those tests that we sometimes do, the relationship. Now, it's an open question, so to the...
Yes, it is for me. Okay, we know that usually we just test the TRABs, but if we have a good testing is to test both the TSI and the TBI, and the thyroid stimulating antibodies are, I mean, a good indicator of the activity of the disease and also to detect the early signs of optic neuropathy. In patients who have an optic neuropathy, there is an increase, and also in patients with Hashimoto and thyroid eye disease, which is, of course, a small percentage, probably 5%, if I'm not mistaken, then it's a good predictor of the activity of the disease. I personally check the antibodies very carefully, and if I see I had very bad experience, for example, in the past, treating upper eyelid retraction in patients who recently have a very mild reactivations of the disease, even with the mild movements of the antibodies, and there are other surgeons in the States who don't rely on that. But in my experience, it's very important.
Dr. Hashimi, what do you think?
I mean, from the other kind of surgeons in the state of Dr. Francesco, I don't always rely for the lid retraction only. When I have a patient who comes for lid retraction, I have a couple of cases. I don't really rely always on the antibodies because the patient wants to have results. So I'm a bit interventionist, but I will offer for this lady Botox injections so they're happy until I have full evaluation and diagnostic and understanding on the biology side. I don't go for surgery, but I try to offer a solution to the patient because sometimes I feel the cynetic of the antibodies is lower than the clinical aspect of the patient. So I usually repeat it after 4 to 5 months. I repeat again the test and to see whether there is any changes. But I go for a solution for the patient because socially it's a handicap for them to have this large lid retraction.
It is a very good point, and you can choose between. There are people who prefer steroid injections, people who prefer Botox, people who prefer hyaluronic fillers. All of them are good, provided their experience. Some people say that now fillers that can be done and repeated are more, let's say, affordable and are more predictability than Botox, but it's up to you. Yes, that's absolutely true. There were other questions that I saw about selenium. I was seeing the question. So they are 3 to 6 months usually.
You take it for 3, you give it for 3 to 6 months, yes?
3 to 6 months. Then they say, is there any consideration doing blepharoplasty in patients with thyroid eye disease? Of course, there is. Some patients just come for cosmetic surgery. It is important to see if there is something more to be done. Usually we remove the fat, we adjust the upper lids. Usually there is always a little bit of mullerectomy to be done in most of these patients. What is very important is not to remove skin from the lower lids mainly. That's a bad mistake. To be very, very careful about lid removal, about skin removal.
Very good. There's other questions about the biologics, immunotherapy. If the TIPRO is not available or not possible to get any other immunotherapy that is effective in, I presume, in moderate to severe. That's probably their question. Thyroid eye disease. Any experience, guys, with immunotherapy?
I don't know if Dr. Netzer want to reply.
Yeah, usually as first line, I will give the steroids for the patient, and if it did not work, and most of the time we don't have the super perfect result, some of the patient I can let's say refer. I do that with the rheumatology team to start on rituximab, for example, for instance. Some of the patient they will show like improvement, and I think it's an option to offer. I know Dr. Habib, who is attending with us, has a different experience with other immunomodulators that works as well. So we have a panel, but none of them is so far FDA approved. And in contrary to the activity in Europe, here we are quite limited by the insurance. If the patient is not covered, I mean, if the medicine is not FDA approved, the insurance will not accept to cover the treatment for the patient. So we have also to deal with this point. So when I was in France, I can, let's say, utilize any drug that I want that has shown in the medical literature efficiency. I'm not limited by the insurance because there is no kind of insurance. But here, insurance also plays a role. But rituximab is one of the tools that we utilize in patient who is not responding.
Okay, same. I mean, of course, we use steroids or surgery if the patient does not respond or there is a relapse. There are other second or third options. One, rituximab, and to refer, but not administered by the oculoplastic surgeons, by the internal medicine doctor, rheumatologist, or in a few cases, tocilizumab. That's another option against IL-6. Of course, I mean, there are different reports, especially for rituximab. There are different studies. Some people say it is effective. Some people say it is not. Sometimes we had some improvement in relapse case. Of course, there are second or third or fourth option, even tocilizumab.
Yeah.
There is questions are keep coming. So there is an interesting question about the the experience of the use of periocular steroid injections in management of TED. Anybody have been doing that, or what do you think?
Personally, I do not use for periorbital. Sometimes, as Professor Francesco mentioned, for the upper lid, when I feel that the retraction of the upper lid is acute and there is some inflammation there, instead of Botox, I can use the corticosteroid for the upper lid retraction. But to do a retroorbital or caroncular or whatever steroids injection, I do not offer that to my patient.
Same. I mean, I've used it in the past for the upper lid. I'm not very confident. I don't like it very much, but it is effective, even if there are some risks. I know surgeons in Argentina who do steroid injections, retroorbital injection. I never did it in my life, personally. So no experience at all.
Also, another interesting question. You have a patient who is very heavily, smokes heavily. What kind of surgical or non-surgical options would you treat this thyroid eye disease patient who refuses to stop smoking? And you cannot convince them.
It's a very difficult question. So, of course, they lie. Patients lie. So most of the time they say, okay, I've decreased, I have not stopped, but I'm just smoking 3 or 4 cigarettes. So in the end, you treat them like the others, praying that they will stop. I have decompressed smokers. I mean, that's a difficult question. I mean, your advice is like patients with cardiac problems. I think cardiologists will always advise to stop smoking, even with stents, but they will operate on them anyway, but they will carry on smoking.
Yeah.
Good. A little bit of some question about the protocol, Francesco, for surgical management of lid retraction that you use. You mentioned that in your presentation. I felt nicely. Maybe you can do like a summary explanation.
Yes, okay. I mean, basically, there is, I think, a good agreement about in the world, I suppose, about upper lid retraction correction. So up to 2.5 millimeters, I would advise to do a posterior approach muellerectomy. And that's quite effective. And you have to preserve a little bit of part of Mueller's muscle lateral. These patients usually don't have a lateral flare, have only asymmetric upper eyelid retraction, and you just preserve a little bit of Mueller muscle, which is close to the lacrimal gland. And they usually come out very, very nicely. For very big retraction, I do an anterior approach graded blepharotomy. That means to incise with a skin crease. Usually the skin crease, I put it lower to the other side because it tends to rise postoperatively. So if I have a 9 millimeters, let's say, skin crease on the good eye, I would put it at 6.57, not more than that. Then I isolate the levator muscle, I recess the levator muscle, I do an anterior approach muellerectomy. So I cut anyway the Mueller's muscle. And then in the end, you will have always a lateral peak. So I cut the conjunctiva. So I don't do the blepharotomy out of the blue immediately. I do a graded blepharotomy. So I recess the levator, I cut the horns of the levator, I do a muellerectomy, then I cut the conch. This is why now I do it together with Decompressions GA, because in the past 10 years or 15 years, I have always been doing the same, more or less. So I don't think it will change that much doing as the contour is necessarily better if you do it on the local. That's my personal idea, though.
Do you utilize a spacer always, or in which situation you will utilize a spacer to recess the levator?
No, I never use a spacer in the upper eyelid. I never use it. I think it gets bulky. I don't like sclerodontine. There is really a reason to use it. And for lower eyelid retraction, I most of the time I use a spacer unless it is very mild. When I do a decompression, I always recess the lower lid retractors. If there is a very big lower lid retraction, I think a spacer is always necessary. And in my experience, the two best lower lid spacers are hard palate and dermal, autogenous dermis. The problem with hard palate is that it is a little bit bulky. And in the past, I had to do a second stage just to soften the bulkiness of the hard palate. It's hard enough, but it's a bit bulky. So it's not cosmetically very, very good, at least in my experience. So I think dermis is a little bit better.
So autologous mainly grafts.
Yes, dermis graft without fat. You can harvest it from the abdominal, from the inguinal region. It's quite thin, and you leave it bare. Suture from the lower edge of the tarsal plate to the lower lid retractors, and it usually conjunctivizes very nicely with time.
Excellent, Professor. I think that's answered very well. I just want to let everybody know that the recording of this session will be sent to all participants, and there is CME that will be also given to the participants. There is a question about the rituximab, Prof. How long do you use it before you say it's not effective in cases of TED?
That's a question for me. I don't know, basically. I mean, because that's
Oh,
not
gee,
just the other doctors or rheumatologists who do it. I mean, they use it rituximab for many different. It's very, very questionable if it is effective or not. It's not very specific for thyroid eye disease. So I'm not sure, actually. I can tell you for other diseases like the dosage in other, for orbital lymphoma, for example, but I'm not sure in thyroid eye disease.
And you're there is a question about, if you're if we are consulted by the surgeon regarding whether thyroidectomy with active thyroid eye disease will be a best solution. What I've seen, and I experienced some cases where thyroidectomy has actually improved active thyroid eye disease. But what do you think, Prof?
I think that you have to stabilize the thyroid function, no matter how you do it. I think you can try with tablets. If tablets are okay, that's it. I prefer, of course, thyroidectomy to radiotherapy, because with radiotherapy, the hypothyroidism follow post radiotherapy is very dangerous for reactivation of the disease. So, I mean, if I could operate on thyroid myself, I would probably do a thyroidectomy in most of these patients.
Great. What is your success for dermal spacer in the lower eyelid? That's another question that's coming up.
Quite good. I'm quite happy. Yeah, the problem is it's very, for me, it's the best spacer. It takes a long time to harvest. So sometimes the patients can use, we can use Permacol, which is porcine, is not exactly the same, which you probably cannot use in the Emirates, and which is a reasonable substitute. The problem with dermis is it takes long, of course, to harvest. I usually do it GA, and the other is LA. It's very important not to shorten the lid. The bad mistake is to do a strip or to do a camptotomy. The lid should be very fixed very well, but not shortened horizontally. I think dermis is a very good spacer for the lower lid, because I started doing this because I started using it to elongate the posterior lamella in socket patients, in contracted sockets, not necessarily with a dermis fat graft, just to improve the lid position, both upper and lower eyelid position. Without a dermis fat graft is much better, in my experience, than mucosa, labial mucosa, or hard palate.
Well, thank you very much, Professor Leoni, and for Professor Hashmi for your participation. I think I'd like to end by thanking Amgen for supporting us in this session and in this series, educational series. It's been really very involved and active and informative to everybody. Thank you for staying longer than the anticipated time, also for all our participants. I look forward to seeing you all again in the session next week, the second session of this series. Thank you all, and have a good night. And
Thank you very much.
Thank you.
care.
Thank you. My
Bye.
pleasure. Thank
Thank
you.
you.
Bye-bye.
Bye-bye.